And the mode of delivery should really be based on routine obstetric indications. There's minimal risk of vertical transmission with vaginal birth, and so a cesarean shouldn't be performed to reduce this. The data from overseas has very varying numbers in terms of cesarean section. The UK has a very high cesarean section rate of 60%. It's not panned out in all of the other data, especially from the US. It does appear to be lower. So I think, again, individualizing what's appropriate for your setting. It's important to think about getting an early epidural, and that's really just to reduce the need of a general anesthetic if an emergent delivery was required, because that's an area of soul generating procedure. As Antonia said, intrapartum continuous monitoring is recommended. There's about a 50% risk of fetal distress, and that's why. Additional maternal surveillance is required, and women may need oxygen that they may not have needed prior to labour. Obviously looking for all the normal things in labour and escalating and investigating if a woman starts to deteriorate intrapartum. Delayed cord clamping and skin to skin is recommended, and certainly having a plan for what you're going to do from a birth partner or support person point of view, knowing that with Delta, the majority of birth partners from the same whole household are likely to be positive. And I think it's really important to make sure that you've been through all the different scenarios as best you can with SIM training. And there's good data sort of come out from some of the UK sites showing that those places that had really thorough simulation training really didn't have an increase in time to delivery for emergency cesarean sections when a COVID case was part of the, when we're comparing COVID versus non-COVID, so definite benefits. What about if you're critically ill? Well, again, this is individualized and should be taking into consideration all aspects of the multidisciplinary team and the patient's preference or their proxy if they're unable to be part of the decision making. Thinking about gestational age and fetal status and what the maternal and fetal comorbid status is, how likely are they to get off a ventilator in a short period of time, and what the potential impacts might be for the pregnancy. And we've heard about the physiology from Megan and the increased risk of hypoxemia in pregnancy and the reasons why we might want to deliver. But it's actually unclear if delivery improves ventilation. And I know that from the UK, there's been a big push that if you're contemplating intubation, you should be contemplating delivery. And as a result, they've got very high cesarean preterm birth rates compared to other studies. But actually, it probably doesn't need to be that. And we need to be a little bit more cautious in terms of rushing to deliver unless there's another reason to. So proning is possible in the second and third trimester, and Tim may talk about that. Mechanical ventilation alone should not be an indication for delivery, but putting it into the context of the whole clinical picture. If you need to deliver someone that's critically unwell, thinking really about what the best location of delivery for that patient will be, whether it's in an adult unit or a maternity unit or in the ICU itself. I think probably ECMO is one where you need to think a bit more closely about the need for delivery prior to initiating ECMO, and that's largely to do with the need for anticoagulation on ECMO, as well as obviously you're at the end stage of disease, and it may be that there is a benefit in delivery from a maternal resuscitation point of view. And for someone that's critically ill, the most likely mode of delivery is going to be by cesarean section. And finally, I know that's not what the talk is about, but just to remind you that the Delta variant is causing more women to become unwell. So in the UK, 15% of women admitted with the Delta variant have required critical care, but importantly, none of them had been vaccinated. So just to encourage you to get your patients vaccinated so we don't have to worry about treatment of severe disease. Thank you.
Claire, thank you. Yes, if Melbourne's got anything to learn from, it's to get the vaccination going quickly while we've still got this window before the numbers surge dramatically. Claire, thank you very much. I can sense in lounge rooms everywhere, iPhones are getting filled with people taking photographs of the screen. I think that all the speakers will be happy probably to share their slides and we'll put them into PDFs and gather them all for you. So don't stress too much if you've missed some of the detail. They've just been terrific presentations. Okay. So on to the deteriorating obstetric patient, and I'm delighted to have Dr. Angela Macris with us. She's the immediate past president of SAMANS. She's an obstetric physician at Liverpool Hospital, so she is in the eye of the storm at the moment. So Angela, thank you. We can see your slides.
Can you hear me?
Yep, sure can. Thanks.
Great. Thanks, Sue. Thanks for the invitation to talk today. And I present this on behalf of Southwest Sydney, as it's certainly been a group effort in order to get these women through. And welcome to our steep learning curve. There we go. So to some extent, it will be a sort of relative evidence-free zone. And we're going to discuss a little bit about the grades of severity, and I'll skip over the bits, obviously, that other presenters have covered, and also the signs and differential diagnosis of decompensation in the mum. So others have put this slide up, and I think I find it really helpful because it helps categorise the presenting patient, and sometimes what feels like moderate is actually mild, and also helps to understand the guidelines in terms of treatment options to be offered for women. So as per the other presentations, I certainly strongly recommend that you look through those guidelines, as I found them really helpful. ARCOG defines decompensation as increasing oxygen requirements, or the requirement for an FiO2 of more than 35%. I think it's important to contextualise this as a change over time, and they're not sort of hard and fast rules, but certainly an increasing respiratory rate despite increasing oxygenation, or a respiratory rate greater than 25. Although again, individually they're markers, but not enough to call it decompensation unless you've tried to fix things. So respiratory rate of greater than 25 that settles with oxygen certainly is a reassuring sign. Certainly drowsiness is a sign of decompensation and an acute kidney injury. A bit like Megan presented, certainly from a clinician perspective, the deterioration certainly is clinically evident 5 to 10 days after symptom onset, and certainly when the fevers defervesce clinically, things start to take a turn for the worse. In terms of decompensation, what certainly is apparent with COVID-19 is that it happens quite quickly. I'm just going to share you a couple of OBS charts of a couple of women that we've got in at the moment. As you can see, the respiratory rate for this particular woman has been bubbling around the sort of 25, 26 marks with increasing requirements for oxygen. And then in the space of 2 hours between a set of OBS, her respiratory rate's up to 34, and she clinically looked really bad, has gone on to be tubed, ventilated, and had a number of biologicals given to her, and thankfully is extubated today. Similarly, another case of a woman who's 39 weeks, who was bobbling along quite stably, and then in the space of one OBS to the other, had quite a significant clinical deterioration. I think it's important to also think about other differentials, and as has already been mentioned, sepsis, either in the context of a pneumonia, that it's a community-acquired pneumonia, or a hospital-acquired pneumonia, women have been admitted for some time, but also the other routine obstetric causes of sepsis, like a UTI. So it needs to be investigated as you normally would, and there's certainly a case for giving antibiotics till the situation can be clarified and then de-escalated. Certainly at our centre, it is considered standard to give antibiotics till the situation is sorted out. Cardiac disease is an increasing problem with COVID, both COVID-related disease in terms of myocarditis or a cardiomyopathy, but also in the context of fluids overload. The high cytokine state makes capillaries leaky, and so therefore patients tend to be more prone to develop pulmonary edema or fluid overload in the interstitium, which will exacerbate what is already a difficult situation with COVID-related pneumonitis. The superimposition or the coexistence of a PE has already been mentioned, and the D-dimer has not been helpful. And certainly VTE prophylaxis for women that have been admitted makes the situation easier. But in terms of full anticoagulation, that's still, as Claire suggested, an area that's a bit grey. DIC can certainly be superimposed on COVID, either as a result of ongoing the inflammatory process, but also because of COVID itself. Similarly, will present with an increasing D-dimer and platelets that are dropping, although those too can be COVID specific without necessitating DIC. The INR, the coags will either be normal, or the INR or the prothrombin time will start to increase, and there'll be either a normal or usually a slight reduction in fibrinogen. Preeclampsia can be superimposed on top of already existing COVID, and certainly we've seen a couple of these more recently where the preeclampsia seems to progress much faster than would normally be the case. I think it affects the maternal reserve, but also means that there is a further increased leakiness in their vascular beds, which makes fluid overload worse and certainly reduces their albumin and their oncotic pressures. So I think it's important to think about who's likely to progress to severe disease or ICU, and this is based on data from the UK, so therefore predominantly alpha variant data, and this is obstetric specific data where in a large systematic review, they found that women who had a BMI greater than 30, who were over 35, who had chronic hypertension as an independent pre-existing risk factor, who had pre-pregnancy diabetes and preeclampsia prior to the onset of COVID were much more likely to progress. But as you can see, the confidence intervals for some of these are quite wide. What was interesting is the women who are not statistically more likely to progress to severe disease or ICU. Multiparity didn't seem to be associated with progression, nor asthma, smoking, or a gestation greater than 28 weeks. The other question that becomes apparent is which clinical symptoms do we need to be worried about, which will suggest that these women will progress to severe disease. Symptomatic is far more likely to progress than asymptomatic disease. Women that present with dyspnea, in a relatively small study from Canada, dyspnea, 100% of women who progressed had dyspnea at presentation. A cough, the presence of a cough is more likely, those women are more likely to progress to severe disease. Chest pain in the non-obstetric population is also an independent marker of progression, although in pregnancy that data remains unverified, and also a reduced level of consciousness. Again, hard to quantify the relative risk. Women that progressed had lower diastolic blood pressures, had a higher heart rate, 113 versus 93, had a higher respiratory rate, which is not surprising, lower SATs, although the difference wasn't great in this obstetric population, 96 versus 98%, and had a higher fever. What is interesting, what was mentioned about the SOFA score, that there's been a couple of studies looking at that in the obstetric population and other predictive scores, and these haven't really borne out in the case of COVID-19. Interestingly, women who present with GI symptoms and myalgia are not more likely to progress to severe disease or ICU. So which investigations will predict a poorer outcome? A CRP of greater than 20, chest x-ray findings. So I strongly agree with Megan that an x-ray is really helpful, even if the woman is relatively seems well from the end of the bed. An x-ray will certainly be an independent predictor that there is a greater chance of progression. Troponin, certainly good if it's negative, if it's got a negative, so it's got a high negative predictive value. However, in the non-obstetric population, it's certainly a marker of progression, although that marker in pregnancy remains to be validated. The higher the ferritin, the greater the likelihood of progression at presentation. So in this particular non-obstetric cohort, a ferritin of 167 was their all-comer ferritin, whereas those that were hospitalised had a ferritin of over 500, and those in intensive care had a ferritin of 1,100 at presentation. The LDH, similar, seems to be proportional to the projected outcome of the patients. Procalcitonin, although it's been used in a non-obstetric population, is difficult to interpret in pregnancy, as it seems to go up both with preeclampsia, other inflammatory disorders, and is not unique to bacterial superinfection. It's also higher than the general population in pregnancy and significantly increases in the third trimester. So I'm not sure how applicable that will be to decompensating women. D-dimer has already been discussed. I'm just going to briefly run over this as corticosteroids. Is certainly of benefit, but only in women who are receiving oxygen. I think that's really strongly emphasised in the guidelines, and the regimes Claire has already discussed in brief. But there is a difference between the RCOG and the Australian guidelines. Australian guidelines suggest 50 milligrams of oral prednisone compared to RCOG 40, and hydrocortisone 50 QID versus 80 QID. As I said before, the usage of corticosteroids for maternal indications only is really only beneficial in those women who require oxygen. The relative risk in terms of all-cause mortality is 0.84 for those requiring oxygen. However, those not requiring oxygen, in fact, there might be a signal for harm. So certainly important to consider that in mother's care. I'll skip over this because Claire's already discussed delivery. In terms of magnesium sulfate, I agree with Claire that I think delivery less than 32 weeks is really optimal to be administered, especially if there's going to be a natrogenic delivery. Optimally 4 to 24 hours is given. I think it's important to note that it is a vasodilator, and so heart rate may increase, and so not necessarily a marker of worsening disease. Most protocols for magnesium come with extra intravenous fluids. Optimally, that could be minimised in order to reduce the risk of pulmonary edema and fluid in the lung interstitium. And certainly there's some lab-based and small clinical trials saying that magnesium is of some benefit in respiratory disease. So I think for the decompensating mother, there's quite a distinct disparity between the Alpha and the Delta variants, that the data unfortunately is lacking behind clinical. And I'd like to thank you for your attention.
Angela, thanks. That was just a great talk summarising the obstetric sort of early warning and decompensating signs, and thank you so much for that. So we're now sort of moving into intensive care proper. And the first person who's going to briefly speak to us is Meredith Healy, who is an RCU nurse at Royal Melbourne Hospital and currently a PhD student. Meredith, some of you might know, she spoke at the RANZCOG International Women's Day, just giving us the perspective of what life was like at the trenches. And so I'm going to ask Meredith if she wouldn't mind screen sharing and just giving us a 5-minute overview of ICU nursing, because I think we've all heard from the media and so forth that it's not really more ventilators that we need. What we need is more people to staff them, and particularly no one can replace an ICU nurse. Meredith, thanks so much. I can see your slides.
And can you hear me?
Sure can, thanks.
Okay, thank you. Thank you very much for this invitation. I thought I might start by saying that giving a little reminder that there are several reasons. My slides are just stuck. Just give me a moment here. Not quite sure why the slide is stuck. Natalie, are you there?
Yep.
Sorry, here we are.
Going ahead, Meredith.
It's all right. Okay, thank you. Yes, I'll start. There are several reasons for a pregnant lady to be admitted to the intensive care unit, of which COVID is just one. It may be a complication of the pregnancy. It may be a pregnancy-related exacerbation of a pre-existing condition, such as a congenital heart disease, and they've gone into cardiac failure. Or it may be completely unrelated to the pregnancy, such as the lady has been in a traumatic accident or they've acquired a non-related infection. So when we're thinking about that, though, every time we have to be thinking about the fact that they have labile hemodynamics. It's been touched on, the fact that their fluid balance can be an issue, their cardiac function, their pulmonary function can be an issue, and we've heard about the anatomy as to why pregnant people have pulmonary issues. And that means that we need to think about the mechanics of breathing and the mechanics of ventilation. And managing a mechanical ventilator is not like driving an automatic car. It's more like driving a large truck where you have to think about a large number of factors to be safe with driving this ventilator. So that means you're thinking about skill mix and who is going to support the patient with all this invasive equipment. We also are thinking about the nutrition, the hematology, the biochemistry, and most importantly of all, we're thinking about the birthing plan. Has that been communicated? Is it possible to happen in the ICU, or should the patient be moved, and therefore we go through all those movements that are needed for safe transport of the patient from one place to another if they're going to theatre for a caesarean section. We also are really concerned about management of the fetus. We're thinking about harm minimisation with all the invasive treatment that we do. We're thinking about appropriate monitoring. We're thinking about placental health because we are using vasopressors that can change the direction of central blood flow. And we're thinking about hypoxemia. How much is too much oxygen? How much is just enough? And then we're also, with the normal patient, we're thinking about logistics. If the baby is delivered, have we got neonatal liaison? Can we get a lactation review if we are going to be expressing the mother? Can we get the milk in a timely manner from the mother to the neonatal intensive care unit, which in my situation at the Royal Melbourne Hospital, we're geographically co-located with the Royal Women's Hospital, so we actually have to go get the milk safely and from one place to another. So now, if we add COVID-19, we're going to be adding severe pathologies. We're going to be adding the restrictions of isolation care and full PPE. We're thinking about sedation management, possibly for a long time. So we have to think about the advanced mechanical ventilation. We have to think about how do we go about optimal position? Do the staff know how to do proning? Do they know how to do proning with a pregnant patient and how to do it safely with all the invasive equipment? Do they understand and can they manage multi-system organ failure with all those extra devices such as dialysis equipment? When the patient is getting better, can they manage the delirium that often comes post a severe illness? And again, nutrition for both mother and baby. And again, a birth plan is even more important because of all the issues and complexities of PPE. Has that been communicated on a shift-by-shift basis? For the fetus, again, we're even more concerned about placental function. We're more concerned about hypoxemia. Sometimes patients with this level of severe COVID and lung disease and their multi-system organ failure, they can be on quite high dose vasopressors, and how can you manage that minute to minute? Again, how often and should we take biochemistry, hematology, metabolic concerns that may affect the fetus? And again, we're thinking about harm minimisation, drug selection. You need your consultant team to be liaising strongly with the obstetric team about that. And is the nutrition we're giving the mother enough for the fetus? Social supports really matter, but they're absent. We do have a telehealth system at the Royal Melbourne Hospital ICU, but the family and the next of kin can't be there. We receive a number of patients who come from remote areas. Hopefully we won't get too many from the Shepparton outbreak, but telehealth is not always possible in some of the remote areas because of communication issues with the NBN. And we also really need to be communicating with the obstetrics team, the management team. There are logistics to that. The physical access may be challenging, especially as this outbreak grows. Phone access will work, and you find the team really accessible by the phone, but sometimes you just need a physical review. How often should the fetal monitoring be occurring? So we found that the patient we had last year was a challenge in all sorts of ways, but the end result was fantastic. Kaylee and Chris happily delivered their twins, and they have gone into the public forum with these photos, and we're delighted to know that we're a small part of producing a happy family. Thank you very much.
Meredith, thank you so much for giving us the perspective from all of everything that ICU nurses do, particularly for pregnant patients with COVID. I'm going to hand over to Tim Crozier now, who is an adult intensive care specialist at Monash Health with a special interest in obstetric ICU patients, and he's going to really walk us through the very, very pointy end of COVID-19 in pregnancy in the intensive care unit. Tim, thanks so much.
Thank you. Can you hear me?
Yep, and we can see you.
Can you hear? Yep, and you can see me. Great. All right. Thank you. Thank you very much, Meredith, too, for that. That's a wonderful insight into what actually happens in an ICU. I'm just going to talk today. You know, we've heard about decompensation, so we're getting into the end where the patients are in the severe or critical illness parts of the framework, the disease severity framework, and so there's a couple of things I think we need to talk about before we go into some specifics. The first thing to say is that when a pregnant woman is unwell enough to come to intensive care, it is an absolute team effort to look after someone like this and look after them properly and hopefully get the outcomes that Meredith was showing us just a moment ago. And so there's no one person any more important than the other. And I think, you know, the ICU nurses, the midwives, the intensivists, the obstetricians, obstetric physicians, neonatologists, anaesthetists, other medical professionals of various subspecialties all play a very important role. And it is absolutely a team sport. And you cannot get the outcomes you need unless you are prepared to work in that framework. The other thing to say is too that we all know that we have a mother and a baby, and we're all trying to do the best we can for both. But sometimes when we get to the sort of sharper end of the wedge, we're usually working on the proviso that what's best for mother is best for baby. But sometimes the choices and the decisions we make can become starker as women become sicker. We can come to that a little bit later on too. Now, proning. So I'll just put this up quickly because we're talking about, Claire was talking about evidence-based and stuff before. Proning is now in the lay press, having gone from a sort of area of in the dark a couple of years ago. And this was the big study on proning, and there's the mortality benefit there, done well before COVID, as you can see by the date. But if you stump up the supplementary index off the website, of course, pregnant women were excluded from this trial when it was originally done. And so I think when we're talking about obstetric critical care, and certainly with a new illness like COVID, we're at the sharp end of the wedge really with patient care, but we're really down the blunt end of the pyramid in terms of evidence. And I think, a lot of what we do is extrapolate and try and do the best that we can with the evidence we've got, which is why the guidelines are so useful, as Michelle talked us through before. So as Angela pointed out, this was, these women can deteriorate very quickly. And these are 2 cases from New York from last year, where women were well, or seemed to be well, and then decompensated very quickly. And certainly the one in the green there. So when someone's gone from 1 litre of oxygen to intubated within 5 hours. And we see that in the non-pregnant population too, occasionally with illness, but women can deteriorate very, very quickly. And here's a series, once again, from the first wave last year. I think this is from Philadelphia. And we look at, five women who were critically ill with COVID. I think the things to look at here are, as we said before, by one of the speakers, you get sick in the 2nd week normally. And so people tend to become very unwell somewhere between day 7 and day 10. A lot of these women too were intubated somewhere between 25 and 31 weeks. A couple of them were proned, and 3 of them delivered during their critical illness, which we'll come to again later on. Sorry. Okay, and this is another Philadelphia case series, and you can see there that of the critical group there, 95% were intubated, 20% were proned, 70% actually met the criteria for ARDS. So there can be a very, very sick group of patients indeed. Now, one thing that makes COVID slightly different from other more classical cause of ARDS is that there was a lot of talk originally with COVID that when you intubated these people, their lungs were incredibly compliant. And by that I mean not stiff. And I think it was mentioned before, I think Megan was talking about the happy hypoxics. So that the problem is not that you have stiff lungs, but you're just very, very hypoxic. And after you've been intubated for a while, it looks like that your lungs get stiffer. And so you become more like the traditional ARDS patients. And so when we talk about the ICU interventions and having to intubate someone or just manage ARDS, this is a schematic, once again, predates COVID, but it's quite a nice little flow chart. You can see there, it gives you a definition up the top, mild, moderate and severe. And then there's the highlighted part in red there at the moment is the mild and maybe having non-invasive ventilation section. And then you go over to the controlled mechanical ventilation section over here. And I won't go into the excruciating intensive care details, but there talks about volumes to ventilate, pressures to keep, and some oxygen and CO2 targets, and then secondary and third sort of line measures if things aren't working. Now, that's all well and good, but in the pregnant patient, as Meredith was saying, we've got other things that we need to think about. And so firstly, we'll talk about non-invasive ventilation. It hasn't had a great rap thus far in COVID, especially with the potential risks to staff with aerosolization and droplet spread. You can have issues with patients who are intolerant of it. There is a risk of aspiration already in pregnancy. The thing I worry most about this, though, is that there's a high rate of difficult maternal airway, or potentially much higher than the general population. And what you don't want to do is get trapped on non-invasives. And by that, I mean people who are getting progressively more pressure and more oxygen. And then you paint yourself into a corner, because then when you try and convert from non-invasive to invasive ventilation, you can end up in big trouble. Because for the reasons that were discussed before, these women can desaturate extremely quickly, and you can get into serious problems And so you'd want to be planning earlier on. And, for that reason, delayed intubation, at least in theory, can cause fetal harm. And guidelines actually say do not delay intubating and ventilating patients who aren't doing brilliantly on, less invasive respiratory support that you've optimized as best you can. So mechanical ventilation in pregnancy. There's a lot of things that we have to think about when we do this. And once again, I won't go into the excruciating intensive care aspects, other than to say, what is tolerable level of hypoxia, both for mother and baby? And we've seen some of the data shown to us before about, people who do well or don't do well with SATs in the high 90s. It may well be that we can get high 80s, low 90s, despite maximal tweaking of everything. Is that enough? There's no evidence to guide us on this. Some studies talk about a P(a)O2 of greater than 70. But there's no good guidance. And once again, on the same flip side of the same coin, what level of CO2 are we happy with? Most ventilatory strategies trying to stop injuring someone's lungs by ventilating them too aggressively with high pressures or high volumes allow the CO2 to go up. And with a placental circulation, we have to be mindful of the potential problems of that. And once again, we're trying to juggle. Should we change our pressure targets? No one knows the answer to that question. There's been, depending on what you read, there are multiple suggestions on changing plateau pressure. There's some evidence in the non-COVID population that maybe compliance is different in pregnant women, but that's pretty sketchy at best. And so we tend to just go for the same targets we normally do. And we certainly shouldn't be injuring lungs in order to try and achieve levels of CO2 and oxygen that they can't otherwise get. There are other things we can try. Deep sedation and paralysis, once again, it's part of the flowchart I showed you before that has effects on the fetus. It's something, there's other effects on the mother. So it's something that we have to be mindful of. And the cardiovascular effects, that's a whole talk in itself on effects on cardiac function of mechanical ventilation, of PEEP. COVID has cardiac effects itself. When we're talking about a cardiac output, pressure and flow dependent placental circulation, and the effects of multi-organ failure. And so a lot of this is a juggle that we have to try and sometimes rob Peter to pay Paul, but mainly just try and please everyone and see if we can walk that fine line. Other therapeutic interventions, people have talked a lot about proning. I don't have any papers here, but it's well described in pregnancy, as people said before. Can be done in second and third trimester. Can be done just with pillows. For those of you who follow the Green Journal, they've got a YouTube video on proning with cushions in the pregnant population. Inhaled nitric oxide, there's plenty of examples in the literature of people using that in pregnancy, including in women who aren't ventilated, interestingly enough, just to gain some oxygenation. Recruitment manoeuvres and ECMO as well. And ECMO and proning, they're asterisk because they're both in the guidelines specifically as things to do in the pregnant population. Fetal monitoring, that's been talked about a fair bit already. As intensivists, that's something that we would liaise very closely with midwives and our obstetric and MFM colleagues about. Different people around the world do different things. There's a real lack of evidence on what the right thing to do is. And once again, I think we just have to say that we're going to try and tailor it to the circumstances at hand. And then there's delivery, which is often the million-dollar question too. Meredith talked at length about the need for a birth plan. And my view on this is that even if it seems unlikely you're going to need to deliver someone, you should always have a plan, and it needs to be discussed at length. And that's a difficult conversation. Things can change very quickly, and there needs to be lots and lots of people who are spoken to about that as best we can. Meredith covered a lot of this before, but other important ICU care aspects: correct positioning. You should never have someone lying flat on their back. There's the skin and other issues that happen with poor positioning. Thromboprophylaxis has been talked about, and the next slide shows the recommendations that Michelle already showed us. Nutrition, skin integrity, bowel care, breast and perineum care, especially in the postpartum woman, partner and family care, medication safety, radiology safety, I could go on. All of these things are incredibly important. So I just want to finish off quickly by just talking about delivery in brief. It's already been touched upon today. Ideally, we would like not to deliver. I think I could probably safely say that as a non-obstetrician in this forum. There are case reports of women being very, very sick and ventilated, extubated while still pregnant. In fact, this woman left hospital and then came back and had a normal delivery and with good outcomes. And certainly there's some stuff that's still in preprint from Canada about exactly the same and trying to avoid delivery unless you had to. But obviously there are, looking at the case series from the last year or so, it's a hostile environment for a fetus in the critically ill mother. And if this case series I showed you before from Philadelphia, so 88% of the women with critical COVID delivered during the disease course were delivered preterm. And in all, 3/4 of the critically ill women delivered preterm. I think that's where close liaison between everyone and good fetal monitoring is really, really important in this situation. And once again, going back to the very first slide I showed, it really is a team sport. This is interesting because a lot of the delivery discussions we have are talking about, you know, will it help the mother? And a lot of the, at least theoretical, attractiveness of doing this is that it might improve maternal lung mechanics and make people easier to ventilate, both from a mechanical point of view, but also reducing their oxygen requirement, reducing the need to modify CO2 and aim for oxygenation levels that you could perhaps relax a little bit more if there was no baby in. And this is a Texas study and looking at the women there. So 50% delivered preterm, 6 for COVID complications and 4 for obstetric indications. And in the women that had ADS, their PF ratio, which is an intensive care term for the amount of oxygen in your blood versus the amount of oxygen you're breathing, improved post-delivery. And their conclusion was that, once again, it requires multidisciplinary care and individualised decision-making, but delivery slowed the deterioration of the PF ratio in these patients. And that's interesting because that hasn't been the experience really previously. There's been several studies done on this and it's always shown mixed results, and delivery wasn't always the maternal tonic that we hoped it would be in terms of mechanical ventilation of critical illness. And this is, none of these patients had COVID, but this is some work we did a few years ago that showed a fairly random change in oxygenation and maternal compliance, depending on whether you're indicated for either fetal or maternal indications. So I think, to finish, delivery is a maternal therapy in COVID-19. It's very little evidence to guide management, which everyone's already stated. There's some theoretical attractions, but there are not insignificant risks. And really, it's a multidisciplinary decision to be made case by case. And the decision making should be made using standard criteria. And really, is it okay to say that COVID is an indication? Probably yes, but not all the time, I would suggest. And that's the end. Thank you.
Great. Tim, thank you so much. That was just great. I'm going to move on now to Adrian. We've heard a lot from Tim about thinking about when do we deliver the baby, what's in the interests of everybody. But now I'd like to hand over to Adrian, who's going to talk to us about, is it better to keep everybody together? How are we going to manage the newborn of the COVID positive mother? Thanks, Adrian.
Okay, can you hear me? Slides okay?
Yep.
Okay, so I'm going to talk about mothers and babies with COVID better together. I guess I could just stop here with these pictures and say yes, and you could all go off and have a cup of tea, but I'm going to go through a little bit of the reasoning here. So just initial experiences, first of all, at the beginning of the pandemic last year, there was quite a lot of conflicting data, case series coming out, very differing practices from where the pandemic began to then where it ended up. So we had some information from China with extremely high cesarean section rates, a policy to separate mothers and babies. None of these babies were being breastfed and there were no infections. Then we moved over to Europe with data from Spain and France and Italy, and these babies are generally remaining with their mums and breastfeeding, often being discharged home and finishing isolation at home. Most of these families got infected. A very small number of these babies got readmitted, and for most of those babies, they had mild disease. And I think just to remind everybody that even though we have all of these fancy machines in neonatal intensive care that we manage babies who are sick or preterm with, one of the most cost-effective things we can do in terms of mother and baby is to breastfeed. So it's one of the biggest returns on investment in neonatal care. And certainly at this point, there was no reported transmission in breast milk. Luckily, guidelines in similar countries did not stay in line with the sort of US and Chinese guidelines. RCOG, College of Peace and Child Health in the UK, RANSCOG here, statewide guidance, all emphasize the importance of keeping mothers and babies together. And you've all heard about these task force guidance already tonight, and the fact that there are perinatal practices in there that all have recommendations. And these are being updated with any new evidence. Most of these are consensus recommendations because of the lack of having these particular practices, such as breastfeeding or co-location, actually asked about in randomized controlled trials. Another question that often comes up, particularly when mother and baby are co-located, is does the baby need tested? Now, most guidance would say that routine testing of asymptomatic babies of women who are close contacts, confirmed or suspected COVID-19 is not recommended. If you test those babies who are co-located with the mothers, it's highly likely they will be positive, but that is not going to change your practice. So in most settings, testing is indicated if a baby becomes unwell or if the baby had to be admitted to a nursery because of prematurity or severe maternal illness, and that might be required for an infection control perspective. As we've heard earlier on tonight, families are very distraught in terms of the potential risk of having a preterm baby, and we know that is more common, and the issues around their families and COVID and information. So for those of you who are talking to parents before or after the delivery of a baby, there are some excellent resources on the Raising Children Network. They link to really good evidence and data, and they signpost back to things like the RANSCOG site. There's some really good resources to point families to. It's important if a baby does need admitted to the nursery for reasons of baby or maternal illness, that the family are supported to see that baby when they have visiting restrictions. So for some centres, there is already existing web cameras that have come in very handy in the pandemic, but people can always send photos. You can have a COVID dedicated iPad where that is kept in the isolation area and used to support families to see the baby. We heard a little bit earlier from Meredith about feeding, but it's important that people understand infection prevention, risk with feeding, or if they are unwell and the baby is preterm, that they understand how to express safely and deliver that to the nursery. So here on the left, we've got some guidance for health professionals from New South Wales Health, but on the right, some really nice, clear information for mothers to follow if they're expressing at home. I'm going to just flick through this very quickly because we don't have a lot of time, but just to focus on the data from UCOS in terms of babies and the risk of positive tests, but also the significant risk of iatrogenic preterm birth. And we have heard a little bit about that already. I know it's not quite part of my talk about keeping mothers and babies together, but certainly a higher risk of preterm birth, a higher risk of nursery admission. You can see there 1 in 4 babies admitted to nursery in the first UCOS data from last year, and I'll come to the most recent shortly. You can see that the majority of babies are not having early positive tests. Those babies who did have positive tests were asymptomatic. And just looking at the bottom half of this slide, just going back to that iatrogenic delivery, and it was great to hear Tim say that potentially COVID is not an indication for preterm delivery, and that all those reasons and the full team need to have that discussion. So in that first UCOS publication, the majority of those preterm births were iatrogenic, 80%, and half of them due to maternal COVID. Just that very small risk in that first UCOS about infants having positive PCR and a concern about, does that mean possible vertical transmission? We think now that's likely to be actual contact transmission because the baby's in close contact. And this data, as people I'm sure know, has been updated just last month. And this is looking at the different waves across the UK in severity. Claire has shown this slide already. So I'm just going to highlight in terms of the baby outcomes across the different waves. So you can see there again an increased risk of preterm delivery. So in the Delta wave, 16%, 32 to 36 weeks, 8% at 28 to 31. And those are increased in the Delta wave for preterm birth compared to the previous waves. You can see this is looking at whether the delivery was expedited due to COVID-19, and that in the Delta wave in the latest UCOS had happened for 1 in 4. This is looking at the perinatal outcomes and the admission. Again, here about 1 in 5 across the alpha and delta periods. There is an increased risk of stillbirth across different COVID data sets, but that doesn't seem to have specifically increased with delta. So just reminding everybody that most of these babies were live born, but many of them were born early, and about 1 in 5 being admitted to the nursery. And just to finish, this is a recent systematic review just published a couple of weeks ago, looking at observational data about some of those important early care practices, keeping mums and babies together. So this is a systematic review, but it is all observational data. So you can see there 4 prospective observational, 1 multi-center cohort, and then we've got chart reviews, case series, and 13 case reports. So only 6 of these 28 studies were actually rated as good quality. And the most important thing to note, if people are looking at this paper, that there is no change in the recommended practices based on this low quality data. We should keep well mums and babies together, that they only are separated if a baby would otherwise have required nursery admission, or if the mother is too unwell to care for that baby. We need to support early skin-to-skin contact, breastfeeding if the mother so wishes, and delayed cord clamping is as the same as standard care. So just finishing this on at first, do no harm, not said by Hippocrates, but certainly embodied in the Hippocratic Oath. Thank you very much.
Adrian, thank you. That was just a fantastic talk. And yes, everybody best kept better together, and better together inside in ICU, and then on the outside better together. Thanks, Adrian, so much. I'm going to hand over to Lisa, who's going to give us just a brief overview of where we're up to with research, what should we be getting our patients to participate in. So Lisa, I'll hand over to you. I'm not sure if you're talking, Lisa, but I can't hear you.
Sorry.
Yep, there we go.
Very much, Sue, and I know I'm coming very late in the running order, so I'll keep it short and sweet. And I just will start off by apologising by just explaining this will be a very parochial talk, just given the role of Melbourne in the pandemic last year. I'm actually just going to highlight some of the bigger collaborations that formed in response to the COVID-19 surge in Melbourne. So first I'll talk about Chopin, which you've heard a little bit about before. That's our registry to look at the outcomes of pregnant women who are infected during pregnancy. The Command project, which looks at maternal and perinatal outcomes more generally in Melbourne and the impact of the lockdown restrictions. And then I'll talk about the Victorian hospital admissions and ED presentations, which are being studied in a statewide Victoria Healthcare Recovery Initiative. And then lastly, I'll just point to a couple of papers from some of the people on the panel and in the audience about the experience of the maternity sector last year. So hopefully it'll be of some interest and some lessons for the rest of you. So Japan, as you've heard, is a national registry of women that requires healthcare practitioners to actually offer them participation and to notify the registry of their cases. So it's completely voluntary. It's under a research protocol, so it's not data that's collected by the Department of Health on pregnancy, and to date there are more than 21 hospitals involved. So the main aims are to monitor the caseload of COVID-19 in pregnant women in Australia, to describe the presentation and clinical course of COVID-19 pregnancy, and to look at their maternal and perinatal outcomes. It is an opt-out mode of consent, which makes it much more practical, particularly if someone's, under all the isolation protocols or is too unwell to consent. They can be consented afterwards. So to date, I have to acknowledge Miranda Davies-Tuck for providing this data. She's in the process of collecting all this and writing it up for the collaboration. There are 97 women collected in the first data analysis. These babies were born between the 10th of July 2020 and the 13th of June 2021. And as you've heard, there was one set of twins. So there are 98 babies that were born to 97 women. And you can see here that the maternal age is about close to the median for Victoria, 30 years of age, 41% in nulliparous, 28% were born in Australia, and sort of odd note, 31% were born in Africa. And when you compare that to the demographics of women giving birth in Melbourne public hospitals last year during lockdown, you can see that that's a very significant difference in the place of birth for these women. And that's due to the location of the COVID hotspots last year. They were in LGAs where there were high numbers of people born overseas, particularly Africa. What were the outcomes of these 97 women? 28% were hospitalised specifically for their COVID-19 disease, of which 2 required ICU or HDU support. 6% had a complication, including respiratory failure, sepsis, acute respiratory distress syndrome, VTE, and diabetic ketoacidosis. 5 women gave birth preterm, which would be a similar rate to our overall population of around 5%. There were no maternal or perinatal deaths and no congenital transmissions of infection. So we are still open for more cases. Unfortunately, it looks like the registry will be very busy in the coming months. So please go to the website here if you want to find out how your hospital can participate. Thank you to Claire Whitehead and Kirsten Palmer, who've been leading this collaboration. The second project I was going to share with you is the Collaborative Maternity and Newborn Dashboard, which is the COMMAND project. So the aim of this study was really to look more generally at maternal and newborn outcomes during the pandemic, to see if there were any adverse indirect impacts of lockdown, telehealth and other changes to our antenatal care. So we have all 12 public hospitals in Melbourne contributing data, and we will be collecting data through to the end of 2022, and quite possibly we'll be asking for an extension to that. The data managers at each hospital upload the data each month to the central research site. And in our last report, we had 38 indicators. So it is evolving. We're working and improving the data reporting, and we present the data as run charts. So weekly outcomes for the main indicators of perinatal care. So 6 consecutive weeks above or below the pre-pandemic median is what's considered a statistically significant shift when you're looking at these clinical quality indicators. So this is an example of one of our charts, just showing the total number of babies born per week. We have 873 births a week on average. And you can see that there was a very dramatic decline in births in November, December 2020, and a rebound baby boom in the beginning of 2021. which is a very typical pattern for births during a pandemic. The preterm birth rate did have a significant decline in November, December. When you look at the weekly rates, there was a period of 6 weeks below the median, and we'll be looking at this in much more detail. This is the chart of unadjusted stillbirths. So this is all births from 20 weeks, including babies from multiple pregnancies with major congenital anomalies and terminations of pregnancy from 20 weeks. So it's just a crude rate there, and you can't see any particular pattern. But we're now at a stage where we can do a much more sophisticated analysis of our data set. We have over 150,000 births now when we include the 2-year pre-pandemic median, and we've been looking at outcomes by defining the women exposed to lockdown as those who spent weeks 20 to 40 of their pregnancy between the 23rd of March 2020 and the 14th of March 21, which was the period of the strictest restrictions. So this gives us 25,000 lockdown exposed pregnancies and 50,000 controls from the same calendar periods in the 2 preceding years. So we've just submitted an abstract to the International Stillbirth Alliance meeting for November 2021, and look forward to sharing results with the delegates there. The third big collaboration in Victoria is the Victoria Healthcare Recovery Initiative. This is a collaboration between the Melbourne Academic Centre for Health, Monash Partners and the Western Alliance, so all the health services and academic institutions in Victoria. It's part of this project, just one small part of this big project, is to look at statewide changes in admissions to hospital, emergency presentation, and outpatient data sets. So there are, we got access to these data sets through a fast tracking process assisted by the Department of Health. The project lead is Professor Harriet Hiscock, and the statistician who's been working very hard on all of this data for the different groups is One YouTube. So I've been involved in the pregnancy and postpartum related diagnoses, and we have some data that's just came out today actually. So we have monthly admissions and ED presentation data from January 2018 to October 2020. And you can see there was a dramatic decline in the number of ED presentations across Victoria from the beginning of 2018 to 2020. And there was also a reduction in the number of admissions for pregnant women for any diagnoses in 2018 during the lockdown period, which is that area shaded in grey. So what has been driving these declines in admissions and presentations? This is the emergency presentation data set for the selected pregnancy related codes. There was a really quite dramatic reduction in presentations for miscarriage or threatened miscarriage. And because these make up the biggest number of presentations to emergency for pregnant women, that's the main driver of the data. So about 8% fewer miscarriages than would have been predicted by the pre-pandemic trend. There was also 10% fewer postpartum presentations and a 25% reduction in lactation-related presentations. There was actually an increase in presentations for hyperemesis gravidarum, 6% above that predicted, and there was no change in the presentations for ectopic pregnancy or complications following abortion, ectopic or molar pregnancy. The hospital admissions for pregnancy-related diagnoses were mainly driven by a really dramatic reduction in terminations of pregnancy. So there were 15% fewer admissions for pregnancies, for terminations of pregnancy than would have been predicted. There was also a dramatic decline in the number of admissions of pregnant women for infectious diseases, and I think we can all relate to that. There were very few admissions of pregnant women with influenza last year. That's one of the small silver linings of the pandemic and the lockdown. There was a decrease in admissions for spontaneous preterm birth, but an increase in iatrogenic preterm birth. So we can't look into this data in any more detail than this, So it's sort of an interesting trend that needs, I guess, raises more questions than answers, I think. And then there were no significant changes in the admissions for hypertensive disorders of pregnancy or mental health related diagnoses related to pregnancy, childbirth and the puerperium. So that's perhaps something reassuring. And then finally, I'll just point to two papers, looking at a closer level at our experience in Melbourne. So this is the Monash Health's experience rolling out telehealth during the pandemic last year. So congratulations to Kirsten for publishing that in the Lancet. And then looking at a more personal qualitative level, this publication by Caroline's group and Zoe Bradfield surveyed 5 different groups: patients, partners, midwives, doctors and midwifery students on their experience of receiving and providing maternity care. So that puts a more human face, I think, on what we went through last year, and hopefully will make us a little bit more prepared to face the coming year. So thank you, everyone. Thank you, Sue. I'll hand over to you to give the closing talk.
Great. Thank you so much, Lisa. Just a lovely talk. So look, gosh, what an amazing panel of speakers, and I suspect all our brains are absolutely bulging right at the moment. Look, we've gone a little bit over, and I don't want people on the panel to not have a chance to engage with all the questions you've got. So unless there's an outcry otherwise, what I might do is just pop a pin in my talk, and we'll do that at some other time. And I might get all the panellists to, if you don't mind, popping on your cameras. And we might start off with some questions. I know Stephen's been curating the questions with Ali, but I might start off with a few of our panellists who we haven't had a chance to hear from yet. And Caroline Homer, if you don't mind, I might start with you. Thank you for joining us. Just terrific research that Lisa's just shown us. And I think in every talk what we've heard here is that no one can whistle a symphony here. We need absolutely everybody. We need everybody who's on this call and everybody who's been making decisions. And I guess I'm interested in what's your sense from the midwives on the ground, you know, who went into a very different sort of specialty than the specialty that they find themselves working with. And I know that this applies to your overseas experience as well as locally here. So I just wonder if you can give us some perspectives on how they're adjusting, what are they feeling, what are the messages in a bottle, if you like, that you might have for them tonight.
Thanks, Sue, and thanks everybody for an amazing evening of talks, really quite extraordinary. I've enjoyed every single one of them. Look, I think for midwives on the ground, and I'm sure this is the same for all the healthcare workers, the doctors, the nurses, all the other providers, it's been a huge roller coaster. I think that slide that Lisa just put up of the effects on pregnant women, our slide on the effects on midwives is basically exactly the same. So fear, anxiety, isolation, uncertainty, having to adapt to change really fast. You know, the email that comes from the health department on Friday morning, and by Friday afternoon you have to tell all your staff to do something different to what they did yesterday, has been hugely challenging for managers and for clinicians. So I think the other thing that's really important for us to remember as all clinicians, and, you know, midwives, as you said, Sue, went into this game with a certain profession in mind, is also to remember that these women are also just having a baby. You know, there's all this other stuff going on, whether they have COVID or don't, but they're just having a baby. And this is the only time they're going to have this baby, even if they're going to have other babies. So really, in the midst of everything, and I know at the moment most midwives across certainly Victoria and New South Wales are in full PPE in a labour ward, and that's a huge challenge. Just keeping the mother and the baby at the centre and her family close around her. And a huge thanks to Meredith for just being so thoughtful around all of that stuff in an intensive care unit as well. So keeping the mother and baby together, and I think Joe mentioned it, just remembering a little bit of joy as well. You know, we've all got our own stuff, and midwives on the ground have huge personal and professional challenges, and they've probably got a bunch of kids at home. They're homeschooling as well as trying to do shift work and everything else. But, you know, most of it is joyful, and really trying to kind of keep the joy in amongst all the stuff. And the challenges. And just final comment about kindness. And thank you so much for Joe for mentioning kindness. I think being kind to yourself to start with. You might not get it all right, and it might not all be as great as you wanted it to be. Being kind to each other. And I think the symphony, I love the image of the symphony, being kind when someone hits a bung note every now and then, and the generosity of spirit, and of course being kind to women and their families. This is a time like none ever, and we all have to get through it. Every midwife, every doctor, every nurse is absolutely precious, and we have to get you to the end of it as well as the women we care for. Thanks, Sue.
Thanks, Caroline. Just a great reflection. BJ, since I'm not going to talk about self-care and leadership, do you want to do a little bit of an impromptu, call to arms about that?
Yes, but I want to do something slightly different, which is that I'm looking at the panel and I'm seeing all of the leaders who have all given up their evening, who are all exhausted, who are talented and have so much to offer. But there's a lot of sacrifice in that. And I was sort of reflecting on my own experience of leadership, which is that I have discovered that it's a lot of hard work. And I actually thought it was just going to be really glamorous and I'd swan around in robes and that kind of thing. And it just didn't turn out that way. Also, looking at everyone on the screen is that I've learned that collaboration is more powerful than going it alone. So working with midwives and nurses and government and health departments and even infectious diseases specialists, they're now cool. And in fact, I sort of think of them now as the sort of orthopedic surgeons of medicine. But I've also learned that leadership is being in it for the long game, because this is already feels like a very long game and it's going to keep on being a long game. And one of the things that we didn't talk about today, because it's been more around obstetrics, but say all the elective surgery that hasn't been done and how we're ever going to catch up on that and all the screening tests and things that will need to be done. And it will affect obstetrics because the whole hospital system. So you need stamina and you need a sort of will to stay the course. And I think the other thing that I've learned is to be humble, because you meet extraordinary people, you listen to extraordinary people, and you don't have to have a pressure on yourself to be the authority anymore. It's almost like that pressure's been taken off us as leaders. I don't feel any need to be the clever one in the room. And the other group I wanted to talk to, Sue, very briefly was our audience, because we've talked, what Carolyn said is true, is that we need to put the woman and the baby at the centre. But I think that we do that. I think that midwives do that. I think that obstetricians do that. I think that's inherent in our jobs. So even though we say it and you hear those lines about looking after yourself, we really have not had sufficient recognition of the impact of mental health during this time. I think that everything's been geared towards preventing the disease, preventing death, the pressure on the medical system. But there is no health without mental health, and I think that that applies to us as much as it applies to our patients, and we mustn't ignore it. And so I think that it's really important that we don't think that we're different. We are not different. I mean, and I can reflect on myself. I was on another webinar this afternoon, and it was about vaccination, and I could see all the angry comments coming through the chat, and it really affected me. And I sort of felt quite sort of sick in my stomach. And I'm so sick of all of this. We're exhausted. We're stressed. We're fed up. We're angry. You know, our buckets are empty as well. And we're experiencing compassion fatigue. And at least I think we should call that out. And I think that we should say it. So I also want to acknowledge all of you and all the people who are on the call, because what we do is valuable. We do care. We are dedicated. We are doing the best that we can. But we're also just normal human beings, and I think recognising that vulnerability is worth doing.
BJ, thanks. Just a great comment and great reflections on. Yeah, it's pretty tough in leadership at the moment. It's pretty tough in healthcare at the moment. The public's perception of us has changed. All of our lives are disrupted in every possible way. Like, this is a time that we experience like no other, and there's never been a more important time for self-care and for very compassionate, courageous leadership. If I can maybe just bring in a couple of our other panellists. I know Alexis is dealing with a Piper crisis at the moment, so I'm going to grab her while she's there. But Lex, we've got quite a lot of regional and remote people on the call, and I guess we've all been talking from the luxury of the ivory towers where we all work, and I might ask Michelle Wise to weigh into this as well, because it probably applies in New Zealand. But just wondering if you can think through sort of just some advice for regional areas and so forth. When do they hang on? When do they send down? What's the Piper perspective?
Thanks, Sue. And sorry, I'm back now where there was a small Piper trouble. So I guess I can speak for Victoria really. And I think there's a few things. Things are still in flux. So, you know, these streaming rules are all still being worked out, and Monash have obviously put all that work in, but there, you know, may well come a point where they can't manage everybody, and we need to work on some other hospitals that become the obstetric streaming hospitals. So for the moment, and I think there's been a few questions in the chat, if your obstetric patient who is COVID positive needs admission, then throughout Victoria at this stage, she comes to Monash. And that may well change, but that's the story at the moment. How do you get her there? If she's got an obstetric problem, then ring Piper. And that's our role in helping manage, is she safe to move? Is she better to stay? How do you manage those things? If she's terribly unwell and needs to be moved, that'll be via ARV for that assistance with moving women who are critically unwell from a non-obstetric point of view. Apart from that, I think probably the message for other sites is that we're all here to help. So through the MFM units, through your links that way, whether it's through Piper, through your link to MFM unit, through the regional kind of setup in Victoria, we're all here to help. So please ring us, please ask for help. The situation changes all the time. And so it's hard to give really clear guidelines, but I think, you know, please call out if there's anything we can do. And, you know, regions that are finding it harder at the moment, like Shep, you know, please ask for help.
Thanks, Lex. Michelle Wise, did you want to sort of comment from a New Zealand perspective? I'm very sorry that we've been very Oz-centric tonight, but just are there sort of things that are different in the New Zealand context and perhaps particularly in that rurality area that you would like to sort of draw out for the New Zealanders on the call?
Sure. So we're very grateful in New Zealand because we are still pursuing an elimination strategy, and our cluster has totaled about 820 cases, and most of them have been in Auckland. So all three big Auckland hospitals are accepting COVID patients. So there's 40 people in hospital at the moment, including a few pregnant women. But of course, the numbers are really small. So I don't think a lot of us are gaining a huge amount of expertise because it's a few people here and there with a few obstetricians. So we don't at the moment have problems with regions and rural areas, except for, of course, everyone being more vigilant, all the antenatal care. So one of the big differences in New Zealand is 95% of our women are being looked after by a midwife, a publicly funded midwife LMC. So really there, I think, seeing the brunt of the antenatal care being done via telehealth and the changes to diabetes screening, for example. But yeah, we've just been very, having great, excellent communication, very clear every single day from our Prime Minister and our Director General of Health. So I've also been really, it's great that RANZCOG has really supported. We have been collaborating with the New Zealand College of Midwives, RANZCOG, and EMAC to consult with the Ministry of Health all year long. So we've really been able to have very consistent messaging from all of the above. So pregnant women have been prioritized from the beginning of the vaccine rollout in Group 3, and now it's really ramping up. We're trying to do a lot of media amongst the obstetricians around New Zealand to get the word out to pregnant women to be vaccinated. So that's our next step.
Yeah, thanks, Michelle. And we're definitely not turning this into a political forum, but I think all of us can't help but look at your Prime Minister and sort of feel like, look, she has been able to bring everybody along, and look, it hasn't been as many hard yards as it's been for Victoria and New South Wales, that's for sure. But she's been able to keep a really tight lockdown going yet again. And so I guess it goes to some of VJ's and Caroline's points about leadership as well. And I'm just wondering if you've got any reflections on just sort of qualities of political leadership that has made a difference perhaps in New Zealand.
I think that's a really good point. It's not which political party you would normally support. We are constantly thinking of ourselves as the team of 5 million. And I think that brings everybody together on board with the same message. And you do see occasional things through social media comments or whatever. But in general, I think, we've also really had low numbers for the whole 18 months, generally speaking. So we also don't have the fatigue that you had in Victoria, for example. We watched that over the ditch. So I think this time when it came around, we had the one case in the community 3 weeks ago, and within 4 hours we were in level 4 lockdown. And when they survey New Zealanders, I think 80% support remaining in lockdown and going for elimination strategy. And we've also had a lot of leadership from academics, consistently saying how that this is the right thing to be doing right now.
Yeah, great. Thanks so much, Michelle. Beck Sabo, I'm so sorry I've kept you sitting there all night, and I know your internet's been a bit dodgy, but the reason I wanted you to join the call was just because you've really led such a lot of the simulation, and I've now lost track of who it was. It might have been Claire, I think, who was just sort of talking about how important it is to do simulation, and that it makes such a difference in terms of things like time to delivery and so forth, and getting PPE on board. You've done some beautiful simulation work on code green caesarean section, elective caesarean section, management of postpartum hemorrhage. Without going through any of those in great detail, do you want to just give us your principles of how you sort of set up a simulation? Because I'm conscious there might be people in rural areas and so forth who have not quite had a chance to do that yet, and we'll certainly share our resources. But what are your go-to keys?
So I think the first thing is to say, and thank you to everybody for some fabulous presentations, and is that all of this is very new. And so we did our first simulation back in March last year, and really with the principle that we didn't have a COVID pathway. And so we actually started with a normal birth from the very beginning of somebody arriving at the hospital at admissions with COVID, and how they would travel through the hospital. So a lot of what we have done is not the traditional, this is an emergency, although we have progressed to that. It really has been rather than it being what we call workers imagined in a room, okay, let's do this, or workers prescribed in the guideline, how is this really going to work in our environment with our teams so that we can plan for any problems going forwards? And so we've, and that really is about, rather than just people knowing potentially what the guideline is, which changes really fast, but being able for them to work together as a team like the Symphony and have collective competence. And some of that has included many of the groups of people that are represented in this panel, because some of those people don't always interact together. So when we've had somebody in the intensive care unit trying to predict what the communication strategies and some of those things. And I know lots of people have had issues with communicating. How do you communicate with the team outside a room when you've got somebody inside the room with COVID? So problem solving, those types of things. We're very lucky to have some two-way baby monitors donated early on, and we have things like the phone set for auto answer. So a lot of it has been what we call testing or planning simulation to create pathways of what will work specifically in our setting and in other settings. As well as then trying to embed those things so that there's team confidence. Because the other thing to remember is that, and I'm sure everybody in New South Wales and Victoria and others, there's like being underwater when you're in full PPE. So it's stressful enough managing somebody with COVID, which is new, and we've heard everybody's tired and fatigued. Trying to do all of that and know that it's going to take 4 minutes to get help in the room is challenging. So what we've found is actually doing that in simulation has helped people cope with that level of fatigue.
Thanks, Beck. Stephen, I'm conscious we're sort of running fairly close to time, and you've been faithfully curating the questions and trying to bring them together so that we can answer as many as we can. And I know many of the panel have been answering questions as we go. Do you want to sort of choose a handful for us?
Yeah, sure. How about we go for the breastfeeding? There's a cluster of questions, and just pragmatic questions with regards to whether the COVID positive mum should use N95, and should there be any need to clean the chest and breast area of COVID positive mums before breastfeeding?
Yep. Do you want me to answer that one? I'll just jump in.
Yep.
So I know certainly, like last year, there were concerns around the cleaning of the chest, and then lactation group had got together to sort of put that into a flow chart. But certainly we don't have data that would say that would make any difference. There's obviously benefits of skin to skin that are due to normal microbiome as well. So it's just standard surgical mask and hand hygiene. We haven't got any recommendations to say that N95 is necessary in that setting. And as I said in my talk, it's very likely that the baby will become positive. But if the baby is well and asymptomatic, so be it. It's better for that mother and baby to be together.
Thanks, Adrian. Carolyn, did you want to make any other comments about that?
Just to completely agree with Adrian. Keep the mother and baby together, do everything normally apart from the mother wearing a mask.
Okay, maybe one last question with regards to breastfeeding. It's the antibody transfer questions. Quite a lot of interest on how much gets through. Is it just around the time of vaccination? And an enthusiastic patient of one of the questions is interested in being vaccinated in pregnancy and then postpartum period, giving some of her toddler breast milk as well.
Okay, I'm not sure about the second question. I'll start with the first one, but certainly after vaccination or after having had COVID, there is definitely demonstrated antibodies in the baby. Not all of the studies have followed that, throughout breastfeeding to 3, 6 or longer, but it would be inferred that being vaccinated allows antibody protection either across the placenta during pregnancy or during breastfeeding. So yeah, the antibodies are definitely there. Just repeat that question about the toddler, Stephen.
The question is whether there will be use to also feed the sibling who's a toddler to give a bit of antibody protection.
Oh, I see. I guess, so I think the sensible answer to that is if somebody is already breastfeeding their toddler, fine. Just do whatever they're normally doing is the answer to that question. Whatever is normally happening with the breastfeeding, keep it going, use the mask and the hand hygiene. Yeah.
And a question which came around when Paul and Michelle were presenting, would it be sensible to at least offer high-risk healthcare workers a booster at this stage? Michelle, I hear one of my colleagues who are older have comorbidities asking that question because they're worried.
I'm happy to respond to that. So we're getting inundated with requests for boosters for not just healthcare workers, but immunosuppressed populations, people who are vaccinated who are not immunosuppressed. It's suffice to say that Atagia are reviewing all of those different at-risk groups. So there's groups who don't respond as well to the primary course of vaccination, and then there are groups who respond very well but are at high risk of exposure and are worried about waning immunity. And there will be advice around booster recommendations, but the priority at the moment that we have to keep going back to is that we still do not have high enough coverage for first and second dose in the broader community. So there's a nice analogy that the WHO use, and I like to use it in talks when people ask me about boosters. So if I have, let's say, a life jacket is the vaccine, and you have a healthcare worker or someone who's immunosuppressed who has a life jacket because they've received 2 doses of vaccine, and I have another vaccine, which is a life jacket, and I've got a whole lot of drowning people next to them who haven't yet had access to 1 dose of vaccine. Will I give my life jacket to the healthcare worker or the immunosuppressed person when I have a whole lot of people who are drowning because they've not been allowed to or able to access a single dose yet? So if we didn't have constrained supply, I think the discussion would be different, but we've just got to remember that one of the best protections for healthcare workers and immunosuppressed populations is vaccinating the broader community to reduce infection in the broader community so those people don't end up in hospital. So there will be a booster program, I have absolutely no doubt, and healthcare workers will receive boosters, but at the current situation with the current doses, with so much of our population who haven't had a single dose, we really need to prioritise them at the moment.
Yeah. Thanks, Michelle. Hey, can I ask a question which I sort of saw floating through a little bit? Sorry to jump in, Stephen. Ryan, can I just ask about sort of the pathways? We've had a few questions come through tonight about private patients, and they might be delivering a long way away from home. This is, potentially in a private hospital, and then they would be referred to the MFM unit associated with their public health unit, and then be going to Monash. And we're just trying to get a bit of clarity, I think, from the private doctors about whether it's regional or whether it's metropolitan, and whether it's an obstetrician or a private midwife. At what point do they do we sort of take over the care, I suppose, for want of a better word? Not take over, but provide support for care.
Yeah, thanks, Sue. I mean, we'll obviously work with them, but essentially the model is for any woman who needs admission. So this is only in relation to admission, whether they're private or public. It doesn't really matter. It's about whether they're needing admission for obstetric-related reasons or COVID-related reasons. They need to be admitted to the streaming hospital, which at the moment is Monash, and that's provided it's safe to do so.
Okay, great, thanks. Stephen, maybe a last couple of questions before our poor panel fall asleep at their computers.
Okay, maybe one for Paul. If there's a COVID positive patient still has symptoms on day 14, what happens with the close contacts in the household with regards to isolation?
Look, that's technically a sort of quasi-legal problem, so that if you're in a household with a case and you haven't separated, then your quarantine clock starts, because you have to do 14 days of quarantine and a day 13 test after the case has been cleared. So the case, this is ongoing concern. The case the person who has the infection, I should say, not a case, but the person who has an infection who's still coughing, provided they're not immunocompromised, will ultimately be cleared at 20 days and could be cleared between 14 and 20 days if their PCR results are reassuring. And it's a panel, that ERP in that diagram I showed you stands for Expert Review Panel, feels that it's okay. So once they're cleared, that's a legal thing. You get a clearance, you're released, you have no obligation anymore to be isolated. Then the people who are in your house, who, by the way, with Delta are usually already positive, but let's say they're not, and manage to somehow avoid it, their quarantine clock starts. The day 0 is the day that the case is cleared, and day 1 of a 14-day quarantine with a legal requirement to quarantine plus the day 13 test starts the day after day 0. So I hope I've answered the question. Thanks.
Yeah, great. I think you have exactly, Paul. Thank you. Stephen, I reckon we might be up to last question.
Okay, maybe one to Antonia. What's the reasons for stillbirth in COVID positive mothers, and is there a correlation with the timing of the infection, and what's the implications for monitoring?
The data from the studies is very mixed about the association between COVID-19 and stillbirth. Some studies saying yes and some studies saying no association. In terms of the causation, I haven't found any of the studies breaking it down by cause. And I guess in terms of common causes of stillbirth in Australia, well, we know that congenital malformation is a common cause of stillbirth, but we wouldn't think that would be it's not any different with COVID-19. I wonder whether in some of the big UK studies that said there was an increase, whether there were delays in women accessing terminations of pregnancy and being picked up when they might have been terminated in earlier gestation, or and also lack of access to care in terms of unrecognised growth restriction or delays in attending care because people were worried. But I haven't seen any good data in terms of causation. And I think that's what's so difficult when it comes to fetal monitoring about what the best strategy is. So therefore, I think go back to the best principles of what are you actually worried about in this patient? Are you worried about preeclampsia or growth restriction, fetal movements, and doing your fetal monitoring according to risk? Because actually the risk of growth restriction is actually quite low if you don't have any other comorbidities.
Brilliant. Thank you very much, Antonia. Well, look, can I just close this evening with my huge and sincere thanks to all of the speakers tonight. Just everybody gave wonderful talks, and it really took us from the very moment of diagnosis. I now know what the public health unit does exactly, and I now know exactly what to do with the baby and the toddler where the mum wants to breastfeed. So from one end to the other, it's just been such a pleasure, and I've been so honoured to have all of you join us tonight. We had, I think, nearly 1,500 on tonight. We've still got nearly 900 on right to the very end. And I know that everybody is very, very fatigued at the moment who are working in healthcare. So it's just a testament to the great contribution that all of you have given. Can I also just send out my huge thanks to everybody who's joined us this evening. We really know that this is a time like no other that we are all working through. It is a time where everything is changing all at once, where we're losing autonomy, where we're dealing with grief and moral distress and fatigue and exhaustion. And it's a challenging time for all of us in healthcare. So can I please encourage you, as both Caroline and VJ did, to just encourage you to please look after yourselves. You can't pour from an empty cup, so please do practice some self-care in a very serious way at the moment. We really need to take care of ourselves and to take care of each other. And look, for those of us in Melbourne, every consultation that you have, vaccinate, because we've got this short window before Paul's curve may be going the same way as Sydney, and it would just be fantastic if we could use this opportunity to get 2 doses of Pfizer into every pregnant woman that we possibly can. So my huge thanks to you all. It's been wonderful sharing the evening with you. We send hugs and solidarity to everybody in lockdown, everybody who's exhausted working in PPE, everybody who is just, or Moderna, says Michelle, yeah, just everybody who is a little bit exhausted with this. We know we all are, but it was wonderful to have this great team together. Thank you for all contributing, enjoy the rest of your evening, and thanks and good night. Bye.